Thank you for everyone who signed in. We're gonna wait for a couple more minutes for other people to join us, and we will start at 8 sharp. Alrighty, my friends, it's time to start. So good evening. Welcome everybody who joined us tonight. I promise this is going to be a fun presentation. I personally love psych, so I hope you guys will enjoy it too. Feel free, I'll be asking questions throughout the presentation, so feel free to unmute and answer, or I'll be also watching the chat, so you can type your answer and send it in the chat. Okay. All right, so my name is Heya Alani. I'm an MS3, just finished my second rotation last week, and my first one was psychiatry. So this is inspired by a real patient, and this patient we've been following them, or actually we followed them then for an entire week. So this is a development over an entire week. We'll also talk about some skills that if you learn now, they're not necessary for you to start medical school, but if you show them on the first day of medical school, your faculty will be very, very impressed. And these skills are pertaining to note taken, especially the typing a SOAP note. So let's start. And this is just a little meme. And so psychiatrists, there is this notion about psychiatrists is that they only give medications. But what I've seen from being there for 6 weeks, even in the inpatient unit, psychiatrists spend a lot of time talking with people, and they also indulge in psychotherapy. So it's actually a combination of effort between psychologists and psychiatrists. The outline of the session is we're going to talk about the case. It is going to be as if you are sitting in this inpatient unit. The nurse will come or the MA will come and tell you about the patient or the case you have. You will go meet with them. We'll develop together a differential diagnosis, follow the patient, and then send them home with a plan of care. And I want you to feel free to engage, participate. I know all of these information are very high level, so I don't really expect you to know all of that. It's just meant to get you engaged, throw any guesses, any things you have in mind. It doesn't have to be correct, really. And I also want you to access the form to the SOAP notes. It really helps to take notes while we're talking, because also this is something you will be doing in the clinical years, and in residency. Oftentimes you're talking to the patient and you're taking notes. This is just the reality of the EMR system. After the presentation, we have a quiz for you. There are like a number of questions. Maybe they're not related to this presentation. They're related to psychiatry and psychology in general. So I'll go back and review these questions, make sure that you guys are capable to answer them. And also you'll have an opportunity to provide feedback on the session. So completion of this quiz is essential to you guys get a certificate of completion, which is really going to help you with your application to medical school. All right, and this is how the form is supposed to look like. Can I get thumbs up from people if you're able to access this form?
I am.
Great. Inpatient psych unit, and a young woman is transferred from the ER to your unit, and that patient is disoriented. You walk into the room, she doesn't give you any information other than her name, which is Carla. She said she was dropped off by her mom, and you don't see anyone with her at this point. She gives you a 10-digit phone number, which is maybe correct because the phone number is 10 digits. When you ask her why she's in the hospital, she tells you that, quote, they're going after me. They killed my husband and now they're going to kill me. You spent 30 minutes in the room with her. And by you, I mean myself. I was a person who spent those 30 minutes in the room with our patient, trying to get a history, but the patient was not giving me anything useful. The patient kept derailing the conversation to talk about how she failed to resuscitate or bring her husband back to life when they killed him. So a lot is going on with this patient. Let's see. What some focus questions would you want to ask her at this point? I know I've said I've been trying to talk to her for 30 minutes, but I'm not getting anything. So if you are able to get 1 or 2 answers from her, what are the 2 most important things you would want to know?
I think what's sort of important is, as you said, they're after her, they killed her husband, and she failed to do resuscitation.
Yes. Correct. So what do you want to ask her?
I would ask her, who are these people? And questions about her husband.
Yeah. So what happened to her husband? Okay, makes sense. Yeah, we want to know who these people are and what happened to her husband. I know the presentation is about psychosis, bipolar, catatonia. So we know this patient is psychiatrically ill, but we can't make this assumption before we do our investigation. This is a really important point. Maybe it was real. It was true that she was being chased down by a group of people who were trying to harm her. So we need to take that seriously before we make any assumptions about the patient being delusional. All right, I like these questions. Who can think of a differential diagnosis? And you don't have to name a disease, but tell me like a problem. And let's read the chat. Let's see what people are saying. Ask her, when did this happen? Exactly. Yeah. We want to know when this, I wouldn't say a constellation of symptoms yet, but when this event happened. Where her mom is, for sure. Like, why did the mom leave? It sounds like paranoia. Yeah. Paranoid people, or people struggling with paranoia in general, have these thoughts. And I always struggle to differentiate between delusion and paranoia, but paranoia is more like not trusting anyone in general, while delusion is having like a fixed delusion, like my neighbor is the one who's out to get me. But paranoia is like, I can't trust anybody. So great point. Thank you, Adam. It could be a personality disorder of some kind. Yeah. For example, people with borderline, they tend to dramatize things to get some attention. So that could be it. Whereas her husband, yeah. And is her husband dead somewhere? Yeah, for sure. We want to know, like, is there a crime that we want to report? Exactly. Maybe she was having some sort of intense hallucination. Exactly. I love that. So if you feel comfortable elaborating on hallucination, when you think of hallucination, what kind of causes do you think that will result in hallucination?
I guess that might be toxins in her environment, maybe trauma, a brain injury or brain cancer. So maybe she might need a head CT. So I'd ask her, maybe when these people came, did she fall or hit her head?
Exactly, exactly. If there's like an instigating trauma, if there's a toxin, you said toxins, that could be anything, but also substance use, like someone here, yeah, I see drug use here. And schizophrenia, exactly. Schizophrenia, people have psychosis. And for a while also, I didn't understand what psychosis is. And really, psychosis means a distorted perception of the reality, kind of like Alice in Wonderland. You see things and you believe they are true. You don't have the judgment to say, oh, this is just hallucination, it doesn't exist. And is she on medication? Exactly. So our problem here is that we don't know anything about her but her first name. And even if like she was a part of our hospital system somehow, um, how are we gonna look her up? Like I had imagined that in the hospital there was a magical way where you can scan people's fingerprint or eye print and then the record will show up. It doesn't exist, unfortunately. So we have to get some information about her. Thyroid electrolyte imbalance, exactly. We're now thinking of more broadly about medicine. It could be a medical cause, not necessarily just a psychiatric cause. Very, very good. You guys are really impressing me.
I check her eyes to see if she has Wilson syndrome, since that could also cause delusions.
I'm sorry, what syndrome?
Wilson syndrome, where it's like a
Wilson.
copper buildup in the body.
Exactly, exactly. So we could do, and I'm jumping ahead of myself, but we could do a physical exam, look at her eye. Do you know what is the telltale sign of Wilson syndrome?
Ah, yes, the gold ring around the pupils.
Yes, exactly. So we definitely maybe we see that, maybe we don't, depending on the severity of the disease, but we also could test their liver function enzyme and see like if they're elevated. But yeah, good. So we have medical causes, brain tumor for sure, brain tumor for sure. So part of her workup could be a CT scan and CMP, which is complete metabolic panel, and CBC to check for her blood, complete blood count. So we do all of these things. And let's just assume, for sake of our discussion, that people, your friends in the ER, they did a CT scan of her head, they did the CMP, CBC, everything came back normal. So now I'm cornering myself and all of us in the realm of psychiatry. And that's probably why they referred her to the psychiatry unit. But I appreciate the holistic thinking, because as a physician, even in the psychiatry unit, you always, always, always have to keep medicine in your differential. So good job, everyone. Well, our problem here is that we don't know anything else about her. So how are we going to overcome this problem?
Well, we have her first name and her phone number. I'd say we use those to check the hospital database.
Yes, exactly. Or something really important in psychiatry is to use collateral, collect collateral information. Could we ask for her ID? Definitely. So for that patient, since she was a real patient, she didn't have anything on her, which is interesting. I'm going to reveal the case later because she was actually accompanied by someone. So they could have at least left her ID. But depending, like my interpretation of the dynamics of the relationship between her and that other person is that the other person was frustrated. They literally dropped her off at the hospital. They didn't help her check in. So this is very, very unfortunate, and one of the factors that are going to limit the amount of care we can deliver to this patient. But we ought to think out of the box. Yeah, her mom dropped her off. So now let's try something. Let's dial this number and see who's going to pick up. Maybe it's a real number. So eventually that's what we did. I don't know why it's repeating this slide. Oh, this is the answers. Okay. So going back to the questions you want to ask, you're going to learn an acronym, OPQRSTADA, and this is very advanced and just FYI, but it's going to help you when you start medical school. So these are the things you want to ask whenever you're presented with a new chief complaint. You want to ask them the onset, which a lot of you guys said that already. Like, when did it start? Did it become worse, better? Did it stay the same? So the progression. Quality is really for pain. So sometimes, like, describe that pain. Is it like sharp pain? Is it knowing pain? Is it like that usually pertains to pain, so we strike it over when we're talking about a complaint like that. Radiation also pertains to pain, like does it move anywhere? And severity, also pain. I'm sure if you've ever been to the ER, they ask on a scale from 0 to 10, so that would be severity. The time or frequency is how often does it happen. So for our patients, it would be really beneficial if we know if that episode happens like every month, every so often. But we try to take that information from her, like, and also when you're talking to a patient and when you're suspecting that they are experiencing some delusion, psychosis, you don't want to challenge them. You don't want to be like, I know this is just all in your head. Like, how often does it happen? No, you want to be neutral. You don't want to confirm it. Like, I know someone is out to get you, and you don't want to deny it. A neutral question would be, is this the first time you're experiencing this fear? So you're still not encouraging the thoughts, but you're respecting that they may exist and they may be real. And we also ask the aggravating, alleviating factors, anything that triggered this incident, anything that led to you feeling that way, duration, how long have you been experiencing this, and associated symptoms. This is based on the differential diagnosis, the things that we're suspecting. We ask other questions. And so let's go ahead and call them on. But before that, midway through the conversation, the patient becomes agitated. She starts pacing the room. You start fearing for yourself because now she is mobile. Although the room in where you're interviewing her, there's no like any sharp tools or any objects she can throw at you, but she is trying to become combative in a way. What should you do in this case?
Well, first of all, you could try calming the patient down. If not, I would definitely ask for an antipsychotic like Haldol or Ativan.
Exactly. Good job. So the first thing you want to do, you always want to be concerned for your own safety. You never want to stay in the room if there is an imminent danger. You try verbal de-escalation of the situation. And let's see, our friends in the chat, try comforting her. Exactly. So try to calm her down. If it doesn't work, if you feel like you're in danger, leave the room immediately. You don't have to be polite about it and say, okay, I'm going to leave you alone to calm down. No, just leave the room, close the door, let the patient simmer down. And in an extreme case, when they're still being agitated, would you consider a medication? I heard benzodiazepine, Ativan, which is lorazepam. What else do you guys know, if at all? Like, this is very advanced, but any ideas what we can give her?
Also, Haldol's good too.
Haldol, yes. So Haldol is a class of medication called antipsychotic. So psychosis, or what we said is a distorted perception of reality, there is a hypothesis about it, which is that it is secondary to some sort of increased dopamine in the brain. So classes or drugs of the antipsychotic class, like Haldol, what they do is that they block the dopamine receptors. When they block the dopamine receptors, they eradicate psychosis. And we only know that because we give people Haldol and they calm down and their psychosis is gone. So this is the idea behind psychosis. Haldol is one of the older ones. It is associated with a lot of side effects. So we only use it in the hospital. We don't give it to the patient to use it on their own. But there's the second generation antipsychotics, and I'll show you guys that in a little bit that we can use. But also one of the second generation antipsychotics that we like to use, which has a similar type of mechanism of action like Haldol, is risperidone. or Risperidol. So let's give an injection to our patient to help her calm down because our attempts to verbally de-escalate were not successful. So we give the patient an IM injection of risperidone, or the brand name is Risperidol, and she goes to sleep. Perfect. We let her sleep for now. In the meantime, let's go ahead and dial the number. So it turns out it really belongs to her mom. And now, this is something unique to psychiatry. We collect the medical history from collaterals, from mom, significant other, boss at work, anyone who can give us any type of information on the patient. So the mom tells you that for the past week, Carla has been acting bizarrely. She hasn't had any sleep for the past 4 days. And this is the first time she experiences something like that. The mother also gives you the following information. So I'm going to give you a tip, guys. Copy this into the subjective part of, I know you can't copy the screen, but take your time to type this information into the subjective part of your notes. All of this is still subjective. So she gives us the name, Carla Benny. She gives us, this is, by the way, a fake name, of course, and a fake date of birth. So name, date of birth of our patient, and she tells us that last month she was diagnosed with depression. Past medical history, none. She doesn't have any chronic medical conditions. And medications, she was given sertraline 5 milligram. PO stands per oral, which is by mouth, a pill. And Q is the frequency. And you always see like some other things after Q, which indicates how often. So Q day is just like once a day. And then there's BID, which is twice a day, TID, 3 times a day. But this is also very advanced, but FYI. Allergies, no known drug allergies, and KDA. Family history, you see that her biological dad has depression and maternal aunt has bipolar 2. Social history, she lives alone since she broke up with boyfriend last month. So, surprise, she doesn't even have a husband. Okay, she works in retail and she denies tobacco, alcohol, and drugs. Now, yeah, no husband. So now we know, like, the mom thinks, no, we know this information comes from mom. So we want to take it with a grain of salt with regards to substance use. Carla could have easily overdosed on something that caused her to hallucinate, but in front of her mom, she never does any drugs. So we want to take it very carefully, but according to mom, this is what we have. And in the chart, you always say according to mother, according to whoever the person gave you the information, because then we want to know how valid it could be. All right, any questions at this point? Okay, I see no questions. Let's move on and see what's going on. So now we learned this information. What other things you're thinking about? I know we said hallucination, we said PTSD, psychosis. What other things you guys are thinking about, and how did this information change your thinking, if any? All right. So in psychiatry, I see an answer here, head CT. Okay. So let's assume that we did the head CT in the ER and there was no brain tumor, no bleeding. So unfortunately, it didn't tell us anything. Could be bipolar with a manic episode. Yeah. So can you tell me? Yes, go ahead. I see a hand.
Yeah, I guess it could also be schizophrenia, paranoid schizophrenia, major depression. We could do a toxicology test and a full blood work if the CT doesn't show anything.
Okay, so we want to do toxicology. So that's different from the CBC. CBC only tells you her red blood count, white blood count, iron, and other things. doesn't tell you if she has marijuana or something else in her urine. So we do urine analysis. So I see bipolar with a manic episode. Do you feel comfortable speaking about why do you think it could be bipolar, and what made you think about manic episode?
I think it's probably bipolar because she was diagnosed with depression, and in order for bipolar to be the main like diagnosis, you have to have at least one manic episode. And in her family history, her maternal aunt has bipolar, and her father was only diagnosed with depression, so she is showing symptoms of both.
Exactly. Thank you so much for sharing. So we saw things like she's been agitated, like everything is up with her, like she's not been sleeping, she's very agitated. All of that is indicative of a possible manic episode. I see Julia. Can we ask the mom, is she had similar episodes in the past? Exactly. So we asked the mom, and she said this is the first time this is ever happening. And I'll tell you how is this useful. But thank you so much for thinking of that question. This is really, really important, and it's going to help us narrow down the diagnosis. If she's not getting enough sleep, that could be also, yeah, making mania something worse, of course. And if someone hasn't had a sleep in like the last 72 or however many hours, 96 hours, it's too much. They could just be having hallucination just by the fact that they're not sleeping. Paranoid personality disorder, yes, so that could be also it. Ask the mom if she has taken any other meds that could have overdose. Exactly. Yeah, so we want to know some medications. I can't think of. There's something synthetic, like synthetic marijuana. I think it doesn't show in the urine. So even if we were to do a urine analysis, sometimes some of these drugs don't show up because it depends on the controls that we have. If we're able to pinpoint what she has in the urine, great. But if we don't even have a control for it, then it will just slide through and we'll never discover. So that could be it. Her mom is a very useful resource, and we can always go back and talk to her again. So I'm typing in the chat the things we have right now. So paranoia. So we said schizophrenia, bipolar with manic cluster A, paranoia, sleep or lack of sleep. And we still are thinking about drug overdose. And I'm sorry if I forgot any, but these all look very valid. So let's do some more investigation. What type of physical exams? You guys talked about urinalysis. You talked about CT, which is really important to rule out tumors or any neurological causes. What other physical exams? Like, we're not talking about labs or images, something you can do to the patient at the bedside that can possibly help you narrow down. Mental status exam, perfect. So in psychiatry, we have our tools, the screening tools. And since our patient calmed down and she slept a little bit, we gave her antipsychotic. So we hope that she has more sound judgment now to answer our questions. So we can use the mental status exam. And there is another very useful screening tool if we're, and this is my differential diagnosis, another screening tool that I'll talk about in a little bit. So there is also something known as brief psychotic disorder. The definition of brief psychotic disorder is that someone who's acting like our patient, they're saying some things that couldn't be true, could possibly be true, but they're not true. They're acting bizarrely, but it's only lasting for a week. So the DSM-5 puts a limit of a week. If it's longer than a week, then we gotta think of something else, maybe schizophrenia. So since we know that it's been it's been a week, I said a week, I should have said more than a week. So maybe not brief psychotic disorder. Bipolar, we talked about it. Depression with psychosis. Sometimes depression itself can be accompanied by psychosis. And how do we differentiate between that? In psychiatry, there is a lot of things that look similar, so bear with me. There is bipolar with depression, and there is depression with psychosis. It's all based on what is the main complaint. Is it depression is the main problem, or is it psychosis the main problem? So it could be that her main problem is depression, and now she's experiencing psychosis. Of course, it could be schizophrenia, and we have a list of criteria for schizophrenia. They have to have one of the 3 positive symptoms, or all the 3 positive symptoms. Forgive me about that. I passed my shift, but there was hallucination, disorganized speech, disorganized thoughts, and there's the negative symptoms when they're like silent, they're not talking, they're not showing any emotions, they have the Joker's face, so or the poker's face. So that is also one of the many symptoms of schizophrenia. There's a lot of things in psychiatry that start with schizo, like schizotypial disorder, which I'm not going to talk about here. But one of the things that could also be the case is schizoaffective disorder, which is you have schizophrenia in and of itself, a standalone schizophrenia, and then for at least a week by itself. And then sometimes you have an overlap between schizophrenia and depression, or some other mood disorder like anxiety. But then that anxiety and depression goes away, and then you have pure schizophrenia. So it's kind of like schizophrenia, but with mood disorder. Could be the case in our patient, maybe, we don't know. Let's see. So we talked about screening tools, but before that, the thing that makes me think more about bipolar is that one very important key fact, which is the diagnosis of depression and sertraline. So I didn't talk about sertraline, but sertraline is one of the first line of treatment for depression, which is a class, the medication class is selective serotonin reuptake inhibitors, and sertraline is one of them. So the problem is, you see bipolar, we have bipolar 1, which is mania, you have that elevation, mania, and bipolar 2 is hypomania. You have a little bit of elevation from baseline, but it's not very bad to the point where you have to go to the hospital because you are being a danger to yourself and the society. And so bipolar 1 or 2, either they can sometimes be accompanied by depression. Bipolar 1 maybe, bipolar 2, I think definitely. You have depression. So it's like baseline going up, going back, going down. So if you happen to be at the depression phase when you go to your doctor, and your doctor doesn't spend time to screen for bipolar, they're going to diagnose you or her with depression. And then the key fact here is given sertraline. Why? Because when you give SSRIs to a patient with bipolar and you treat their depression, they're going to jump to mania. It's going to invoke their mania. So they always tell you never treat depression or diagnose someone with depression until you ruled out bipolar, because if you start treatment with SSRI, you're going to put them in mania. So to me, since I know this fact, the first thing that came into mind was, oh, could it be bipolar because we just gave her sertraline? So right now, can we agree that bipolar maybe is on the top of our differential? Who agrees and who doesn't agree? I welcome all opinions. Yeah. Okay, right. So we talked, our friend said mental status exam. Exactly, the idea is to use screening tools. And these screening tools are based on extensive research, and people are using them for a reason, because they proved validity. So let's use one of our screening tools. And in this case, we are going to use something called the Mood Disorder Questionnaire. And you don't have to know all these questions. In fact, you'll never ever gonna memorize all these questions. You'll always have a piece of paper, ask the patient, mark the questions yes or no, combine the points, add them together, and see what is the cutoff. And then based on that, you also based on your clinical judgment, you make the diagnosis. So we went into the patient. She's sitting on her bed. She's doing well. She's talking to us. We did the screening, and turns out that she has, or she qualifies for bipolar. That's the other thing that I learned in psychiatry. Actually, when we discharge her, the diagnosis says psychosis disorder or suspected bipolar, even when they started the medications. It is not confirmed until we treat her for a little bit and then see if she's improving. It means we were right, and we can say 100% that she has bipolar. And bipolar especially is very, very tricky to diagnose. And most often you diagnose people when they're in the hospital, because then you have the opportunity to watch them over a period of time as opposed to in hospital visits. So she qualifies for bipolar. How do we treat bipolar? This is a teaching point. Treatment is at the hospital, like our friend said here, we give them antipsychotic, whether it's lorazepam or Ativan, any type of benzodiazepines to calm them down. And benzodiazepine, my friends, is something that shuts off the brain. It encourages the GABAergic neurons to work more efficiently. So any overactivity is quelled or turned down. Then maintenance therapy, we want to use some things called mood stabilizers. And we have few options. We have things like lithium or valproic acid. So now like with any medication, especially in psychiatry, you always want to make sure that the patient is not pregnant. Lithium is very teratogenic, and it causes, just FYI, something called Epstein anomaly in the baby's heart if she happens to be pregnant. So there's this one internal medicine faculty who taught us that every uterus is pregnant until proven otherwise. So you always want to rule out pregnancy before you start medications that could affect the fetus if there's pregnancy, like lithium. So let's see, we screened her, she's not pregnant, so we can comfortably start lithium and or valproic acid, depending on many factors like her insurance coverage, the availability, things like that. We talked about antipsychotics and how they turn down or tame the dopaminergic activity that causes psychosis. So the antipsychotics, haloperidol is one of them. This is the older generation, but they have a constellation of side effects. That's why we don't use them very loosely outside of the hospital setting. And we use the atypical, and risperidone is one of them. Also, this type of medication, each one of them has a constellation of like side effects. So based on your patient profile, you also want to decide what medication to give them. Some of these medications cause diabetes or liver dysfunction. So if you have a patient who has diabetes or a family history of diabetes, you want to avoid this medication. One of them is olanzapine. It's very known to cause metabolic syndrome. So for our patient, she's healthy. She doesn't have a medical history. Let's give her risperidone for now. Okay, any question on antipsychotic and bipolar treatment? All right, I see no questions. So let's see what's happening in the case. So the next morning, the nurse calls you and tells you that the patient has been staring at the ceiling, not moving, and not responding to anyone for the past hour. She described the patient as a wax figure, where like if you move her limb, it stays like that. It doesn't fall back down. So what do you think is going on? Have you guys ever heard of this possible new exacerbation or disease? Yes, catatonia, exactly. So I know like the description is very telling, but in the hospital, you always have to do screenings because you have to document with confidence that this is catatonia, and also for the sake of billing and insurance. So let's see what we can do to confirm that she has catatonia. We use something called the Bush-Francis catatonia braiding scale, And this is actually not only it is a screening tool, it's also things that we do to the patient. So it's not just like in the previous case, we asked the patient questions and they like they said yes or no, and we check the boxes. These are things we do to the patient. One of them, which is really cool to me, was when we have this gentleman who was suspected of having catatonia. We walked into the room and my attending told me to scratch my head, just keep scratching my head and see if they are going to imitate me. Because this is one of the things that people with some types of catatonia do, is that they mirror or the exaggerated movement of another person. So it is very cool. I encourage you guys to watch. People do that type of screening on YouTube. I hope it's available. So yeah, there are like different maneuvers and things you do to the patient, and you rate the result or the outcome, and then you add up the points and it tells you if this patient is suspected of having catatonia. Also, always take these screenings with a grain of salt. Base things on your best clinical judgment. For our patient, it was borderline, but when we went down and we saw him, it was clear that he is catatonic. To me, before I went into the psychiatry unit, catatonia sounded like a state of euphoria, or like patient is over agitated, which is partly true. I'm going to tell you about the types of catatonia in a little bit, but there is like this one end of the extreme where patients are very moving, very active. I mean, moving, doing things, and there's the other end where patients are very immobile. They're waxy figures. They're not responding. So I want you to keep that in mind when you think of catatonia. And for the board question, it's always the keyword is waxy figure. All right, so how do we confirm? So we have the screening, and the screening tells us, yeah, maybe he has catatonia. So how do we confirm? This is also very mind-blowing, my friends. You give them lorazepam, 2 milligrams. In a few minutes, they just go back to normal, as if nothing has happened, which is really, really crazy. I encourage you also to look up some videos, and you'll see that it's very similar to a magic wand. Like, you give them lorazepam, you wait a little bit, and they're back to normal. They're talking to you, they're sound and safe and everything. So yeah, lorazepam is one thing we do. Maybe sometimes we continue using lorazepam to prevent them from going back to the state of catatonia, but sometimes when it resolves, it resolves. Other times, if we are worried about addiction, especially in the younger population, in a patient with substance use history, we don't use benzodiazepines, which end with PAM or Zpam, because these also carry the risk of addiction. We use something called zolpidem or Ambien, which is a sleep medication. And also the Ambien challenge is another type of challenge that you can do. It can also give you the same outcome. Patient can revert back to normal very quickly. And if you're worried about them going into catatonia, again, you can discharge them home with zolpidem. Zolpidem is not this type of drug that will cause addiction, but also it is not recommended to be prescribed for the longer run, because people can depend on it and forget about their sleep hygiene and forget how to feel, how to fall back to sleep normally without using the medication. So just something, to keep in mind. There are other options, other benzodiazepines, other than benzodiazepines. All right, so catatonia, this is a picture from Wikipedia and from Google. This person is a real person, I'm assuming, and he is a waxy figure. Our patient looked like that. But there are different types of catatonia. So there is akinetic catatonia, which are like people are staring at the ceiling, immobile. They don't talk. They don't move at all. And you move their limb and it stays like that. So this is akinetic. You have excited catatonia. They're agitated. They're restless. They imitate your movement. And it kind of sounds like a person with Parkinson disease. And there is malignant catatonia, and that is accompanied with things like delirium, fever, sweating. And of course, you want to address all of these because they can affect the electrolytes balance, and they can lead to other adverse outcomes like heart arrhythmia and things like that. But just to give you the full picture, the full picture on catatonia. All right, so we treated our patient. We gave her lorazepam, and she reverted back to normal. So she is not suffering from any of the psychosis symptoms anymore, and she is not suffering from any of the catatonia symptoms anymore. We observed her for 3 days, and the attending told us she is ready to discharge. So what is your plan for this patient? What are the things you want to address? And I encourage you to think of medications maybe, and also other things other than the medications that will help support her. Continue with psychotherapy. Of course, yeah. We don't want her to hopefully come back to the hospital again. Change her sertraline prescription. Yes, definitely. Sertraline was a cause of the problem, so we want to discontinue the sertraline. What else can we do for her? Think more about the social determinants of health. You guys, when you apply to medical school, make sure you address the social determinants of health. It's becoming, happily, I'm so happy for that. It's becoming increasingly more important to talk about social determinants of health. We saw that her mom just dropped her and didn't care what was going to happen to her, didn't even check her in or give her ID. So maybe we want to make sure, talk to her mom, and assess her situation at home. Is she safe at home? We know that she lives alone. Is she capable of living alone? How is, is there like an element of abuse? She ensures she has a support system. Exactly. To the best of your ability. Yes, thank you so much for mentioning that. Sometimes we can only do so much. Yeah. Support groups. Exactly. Yeah. Talking to people who have similar problems always helps. So make sure that also the social aspect of things is addressed, and she has all the resources that will help her transition from her hospitalization to going back to normal life, and hopefully to her job, and hopefully to living independently and safely. All right, so let's see what we said here for the plan of care. This is also something that's going to help you when you write any patient notes, and it's kind of repetitive. You write it in the subjective part, and you write it again in the assessment and plan. So when you talk about a patient, there are 5 or 6 elements that constitute your opening sentence, or we call it the framing opening sentence. Whenever you're presenting a patient, you start with their full name. So Carla Benny, their age, 22-year-old, and their ethnicity or racial background. So I didn't choose an ethnicity or racial background for our patient, but we can say something like she's a Caucasian female, and then her gender. And also I encourage you to think about more inclusively, like a cisgender female, a transgender female always helps, especially when it comes to mental health. And after we mentioned the name, the age, the gender, and racial ethnic background, we want to tell the person who's listening if she has any past diagnosis or recent diagnosis that can contribute to her final diagnosis or our treatment for her today. So I want to tell my attending that she was diagnosed recently with depression, because that's going to tip them off to think about bipolar, secondary to treatment with sertraline, et cetera. And also a family history. So this past medical history of hers and the family history, all of it is considered risk factors related to her life, whether it's a medical history or social history. Something like, we could also have said something like with with substance use disorder or with a history of exposure to marijuana, etc., etc. So after the gender, I want you to think of all the risk factors, medical and non-medical. And we talked about her family history, and then now why was she admitted? Who was admitted to the hospital today? Of course, like the tense of the sentence doesn't make sense because she was admitted to the hospital, not is admitted to the hospital. But let's just assume that I'm presenting on the same day. So who's admitted to the hospital, or who has been admitted to the hospital for bizarre behavior. So now we're telling the presenter, the listener, why we admitted her to the hospital. And the subjective portion is always in patient's own words. So I know we didn't talk to the patient, we talked to the family. That is why we use the words they use. I'm not going to use for bipolar here because that is a diagnosis, and diagnosis is going to go in the portion below, which is the assessment and plan. When I'm talking about the subjective part, it's always only what the patient is telling me, and then my critical thinking and my judgment will come later. So she was admitted for bizarre behavior and agitation and lack of sleep. We did a physical exam, and I should have elaborated, said mood disorder screening or questionnaire indicates the diagnosis, maybe possible diagnosis of bipolar with mood disorder. So this is our final diagnosis of her. Usually, if you go back to the rest of the note at some point, because this is also a unique case, so I don't want it to make it complicated for you. I know there was a change of events and she had catatonia. So when you look in the charts in a hospital, in real charts, you'll see something every day called progress notes. And it tells you last night she had catatonia, last night this and that happened to her. But for our purposes, let's just assume that we saw her one day and we discharge her in the same day. So for your guys' notes, I don't want you to talk about catatonia because that's going to be like for a full course of treatment or a full hospital stay. So catatonia was just, to entertain you and to show you some cool things in psychiatry. But ideally, we'll have something a line that says her hospital course was complicated by an episode of catatonia, and she responded positively to lorazepam challenge. That could be one line that we could include, and feel free to include it if you want, but it's not necessary. So the plan, I was just taught for the past 2 months to do the plan in terms of a problem list. We have this problem, how we want to address it. So bipolar, we want to discontinue sertraline, like you said, and start lithium 600 milligram per oral every day. For mood symptoms, the lorazepam or Latuda is actually an antipsychotic, but it also has properties to treat depression. So we know that she has bipolar with mood disorder, but we can't use SSRIs to treat her depression because we're going to invoke her mania again. So we want to use something that's more friendly and more suitable for her disease. And luckily, in the class of antipsychotics, we have something that also works for depression, which is lorazepam. And I would also include the dose here. I should have included that. And but for your guys' purposes, of course, it's not necessary to learn the dose. And surprisingly, also, even as a 3rd and 4th year medical student, you don't have to worry about the dose. And lastly, follow up with outpatient psychiatry. We want to connect her with a psychiatrist who sees her on a regular basis. And we can include a 4th point, like you guys said here, refer her to a support group, or make sure she has a person who can take her to the next doctor appointment or something like that, a social element or social determinant of health element also into the plan. So with that, I see something in the chat. Is medication the best treatment with mental disorders? That's a really, really good question. I personally believe it's a combination of both. Sometimes some things like depression, you can argue that psychotherapy alone is sufficient and is successful. But for people like people with bipolar who have mania, um, you have to use medications because there's the risk of having mania again and having all these dangers happening to the patient. Like with mania, they could also commit suicide because they feel so euphoric and they feel like they're undefeatable, so they can jump in front of a car. We actually had that patient who was having a mania and he jumped in front of a truck just for fun, not because he wanted to commit suicide, but he could have killed himself. So yes, in these extreme cases, you need medications, but definitely you also need psychotherapy. And it's a good segue to my final point, which is lithium. You want to continue it indefinitely. For people with bipolar, you always want to keep them on mood stabilizer. If this patient decides to become pregnant at some point, switch the class of medications, but always keep her on some sort of medication. Great question, thank you. Any other questions? Okay, I see no questions. So I had so much fun presenting this case and working through this case with you guys. I'm very, very impressed with your information and with your critical thinking skills. And I encourage you to come to the rest of our virtual rounds. They're always going to be fun. And we have a variety of cases ranging from medicine to surgery to psychiatry. The next step would be to take that quiz. I'll go back and make sure that the quiz questions are fair. So you guys can score 80%. And when you score 80%, you'll be emailed a certificate of completion. And you have, in that link, you have a Google folder and it has some other resources, maybe on this topic and other topics. So feel free to check them and, enjoy reading about psychiatry. We hope to see you for our next session, which is going to happen also on Wednesday at 8 p.m. Central Time. All right, so any last questions? Thank you so much, Shirley, and thank you everybody who attended today. Good luck with everything and enjoy your evening. See you next time.